Now we talk about non-invasive ventilation, which is same as mechanical ventilation invasively done. Both deliver positive pressure, but the very basic difference is the interface. Here the interface is a mask which fits on the face, and it does not produce such a good seal which an ET tube would do with the trachea. So it's a leaky system. Some amount of leak of air is expected. And the other reason for the leak is the masks which have vents. The NIV can be delivered even with a conventional invasive ventilator with a dual limb circuit. There, when you use the interface, it should be non-vented because it already has an expiratory limb. But when we use the single limb tubes with conventional bedside NIV devices, they do not have an expiratory port, which has to be there somewhere in the mask. And those are called as vented masks. So that is another reason that these systems are slightly leaky. Mask should be on the right side. We generally use a face mask which fits from the bridge of the nose to the chin. And when applying the mask, always consider will it fit the face well. And that is where the fit issues come. Edentulous patients or patients who are emaciated with bony prominences, there the mask may not fit well. Or in patients who have some kind of swelling injuries, they are best avoided because not only the mask is difficult to apply, but the airway may also be threatened in those patients. And because there is no ET tube, we got to be sure that the airway is protected. So we generally choose a patient who is awake, responsive, and requires some form of ventilatory therapy. And the mask ventilation also predisposes to the risk of infection because the air goes both inside the stomach and the lungs. Patients frequently complain of aerophagia, fullness, and they may aspirate more likely if they are put on an NIV as compared to giving nothing. So you should always be careful about the risk of aspiration. The terminology used generally is the IPAP and the EPAP. The IPAP is the maximum pressure, the inspiratory positive airway pressure, and EPAP is the expiratory positive airway pressure. But unlike in invasive ventilators, the support provided by the breath is actually IPAP minus EPAP. For example, if we set an IPAP of 10 and an EPAP of 5, the support provided with each breath is actually 5. Whereas we take invasive ventilators, look the EPAP as peak, let's say 5, and we put the pressure support or in the pressure control mode a pressure of 10, then the total pressure delivered would be 15. Here the total pressure delivered is maximum is actually the IPAP. This terminology should be kept in mind. We generally start with lower pressures because patients are conscious, they may not be able to tolerate the flow of air. You really got to reassure them. The mask is a claustrophobic feeling. It's not a great idea to breathe out against positive pressure. So we will start with EPAP of 2, 3, 4, maybe like that, and IPAP of maybe 6 to 8. Whatever your unit advises or preaches, we follow that. And we titrate upwards. We build up the pressure slowly. This can be prefixed in the machine, but it is best to reset. So unlike in invasive ventilators where you have decided what is to be put, you have sedated, paralyzed, you are in total control, here things are more dynamic. And so NIV requires more monitoring when you start it as compared to an invasive ventilator. And here comes the low threshold for invasive ventilators. These patients are someone who requires some form of ventilation and you have chosen them for NIV. If at any point of time you feel the airway is threatened, just intubate. Or if you think the NIV is failing because of whatever reasons, the pressures which can be delivered by NIV are limited because higher pressures are not tolerated, and the bedside machines also have a maximum EPAP of 20, 25, some machines may give you 30 but not more than that. Sometimes that may not be enough. And the condition may deteriorate, which may require invasive ventilation. Invasive ventilation works more predictably, maybe faster. So when you have to take decisions in a patient who is sinking fast or who requires some kind of urgent correction, it is better to do invasive ventilation. Have a target in mind, what you started with. It could be the heart rate, the respiratory rate, the saturation, or maybe a repeat ABG to look at carbon dioxide levels and to see whether they are coming down or not. Improvement should be recorded over the first 2 hours. And the other thing which has to be taken care of, secretions. Patients cannot cough on an NIV well, they cannot take out their secretions. Somebody who has a lot of secretions, you have to remove the mask to let them spit out, but that may not be practical. You cannot suction these patients like you do in an ET tube. So secretion handling becomes a major problem. The airflow also makes the secretions dry. The dryness of the mouth and the airway is comparatively more with non-invasive ventilators than with invasive ventilators. You can use heated humidifiers, you can use HMEs, but still the incidence remains small. It may be the only mode of ventilation that you require. It may be a ventilation that you take a chance upon in a patient who may or may not require invasive ventilation, you are not sure and you want to see improvements. And it may also be used for weaning. So your patient has been on an invasive ventilator, requires some kind of respiratory support, and you switch over from an invasive to non-invasive ventilator. And this choice is mainly because we can take the external airway out, which is the ET tube or the tracheostomy tube, because the major risk of infection in a mechanically ventilated patient is because of the bypass of the upper airways and the presence of a foreign object, which is a tube. The same thing should be kept in mind in an extubated patient, because the upper airways are bypassed when you intubate the patient or put in a tracheal tube. But as soon as you take them out, they also come into play. Patients who are obese, have thick neck, have obstructive sleep apnea, these are patients who will actually require a lot of pressure even to open their upper airways. And these are patients who are given a higher EPAP to open their upper airways so that the airflow remains smooth during inspiration. Disconnections with NIV are frequent. The patients are awake, they can respond to you. You can hear the voice even from inside the NIV. They may ask for water, they are thirsty, they are hungry. You are not sedating them. It is not a patient who is on an invasive ventilator, you have put them in a RAS score of -3 to -5, you are taking care of the feeds. It doesn't happen like that. Many of them are taking orally, many of them may ask for water, many of them may want to talk when the attendants and relatives come. So you should choose a patient in whom you can disconnect for some period of time and put the orders right. How much time can you disconnect? For what are you disconnecting? How well the patient tolerates? What should I do in between the disconnection time? How much oxygen should I give? And what happens if the saturation doesn't improve? Should I apply the NIV back? This should be well recorded, because disconnections of 1 to 2 hours are also not uncommon, and we generally do them when we feed them, because as I told you, the stomach is now full with food, and then you put NIV, a lot of air goes in, patients feel a lot of discomfort and they might vomit. So you should know if I can disconnect and put it right on the papers, how much time you disconnected and what happened. And this is a major challenge in acute hypoxia. It is increasingly being used in mild to moderate ARDS, but ARDS is an acute hypoxemic condition. You apply an NIV, you probably would not be able to disconnect it for long, and that becomes a very uncomfortable experience for the patient. You cannot use non-invasive ventilation non-stop for 3, 4, 5 days. You can do that if you can really communicate well with your patient. He tolerates it, yes, but these are unusual cases. Otherwise, generally it's an intermittent therapy. For some patients we may use just at night maybe, and some patients we may use intermittently during the daytime or not at all. That depends on the clinical condition of the patient. Eye care assumes even greater importance. As I said, the mask is there around the face. The leaky air can cause a lot of dryness of the eyes also. Skin care, especially of the facial skin. Sores due to masks are very common. They are one of the things that you should look in device-associated pressure ulcer monitoring. You should maybe apply some kind of tape or this protective covering, anything which you can choose. But make sure that you do not leave a bad scar or bad mark on the face. It's so visible. Oral care, as I said, because drying of the mouth is very common, you should take good care of the oral cavity and feeds, how they are to be done. If they are on dry stew feeding, which sometimes we may encounter in some patients, then you can switch over to continuous feed. But most of these persons, as I said, would be awake and alert, so they might be eating orally. Whether you need to give them small frequent meals, how will they tolerate the meal, how bad they feel after the NIV is connected, should all be recorded. The major indications where we use, okay, it's not like an invasive ventilator, but used for similar purposes. COAD is probably the classical description where we can use, because we can disconnect them intermittently. The pressures required can actually be enough for the patient to ventilate well. In pulmonary edema, it's a class 1 indication, but look at a pulmonary edema patient. He's restless, he's tachycardic, he's tachypneic. He may not like a mask against his face. And if there is an ongoing organ damage, cardiac ischemia, you need to do something fast. The same class 1 indication, but you may have to invasively ventilate because you would like them to get sedated. You would like to take control of the breathing, bring down the excitation, control their heart rate, the BPs, their oxygenation fast. So the decision is very, very dynamic. In acute pulmonary edema, the other thing is if it is cardiogenic pulmonary edema, the response is also dramatic. So you may apply an NIV, leave it for a small period of time, in an hour, 2, 3, and you may see a turnaround. That gives sometimes a diagnostic clue that probably my patient had cardiogenic versus non-cardiogenic pulmonary edema. And palliative care, obviously. All patients who need end-of-life care, they need some kind of respiratory support. You can choose what you need to give them, but NIV comes on top of the list because you can keep the patients conscious, that is one. You can avoid endotracheal intubation and maybe also send the patients back home on an NIV. The success of the NIV system depends on the choice of the patient, but is tremendously dependent on the support staff or how well the monitoring has been done, because things can go wrong on an NIV. And the monitoring in the few first hours of therapy is very, very important, especially the response as well as the condition of the airways. So nurses take a big role in non-invasive ventilator also because they frequently disconnect and communicate to the patient. So you should be well versed with the use of NIV, and in all units who successfully use NIV have a support staff which does excellent job.